It can be tough out there in general practice land. And to mark Stress Awareness Month in April, the BMA released a document called Managing Workload and Taking Time to Reflect on Wellbeing for GP Practices. They suggest that we make it a monthly practice to reflect with our teams on well-being. They also present practical suggestions for managing workload more effectively in practices. It all might even help you achieve your mandated quaff Steph well-being points. Gandhi and I took a look at their advice and have split our thoughts into 2 episodes. This is part 2, where we discuss their advice for managing workload. Look out for part 1, where we reflect on how to implement the advice about well-being in practice. Let's tech enhance your primary care and learning.
Also, there is some stuff on workload that it mentions in this particular document, and I think that is also quite useful to have a look at because it can further support some of the challenges you may be facing. So we're going to have a look at those now, and in particular focus on some really key areas on safe workload. So it talks about appointments and how to categorize them, and we talked about that limit. So it mentioned 28, so it says 25 to 35 contacts per day in terms of whether that's online, telephone, or face-to-face. And how that can then support more holistic care by freeing up capacity for you to deal with it more effectively rather than just bashing through loads of contacts and that kind of stuff, doesn't it, Andy?
Yeah, and I was talking to BMA representative, and I asked the question actually, what about EConsults? It just uses the word remotely here. They said, well, an e-consult is a consultation. You're processing information, you're making a decision. That counts as a consultation. And actually, this range, 25 to 35 per day, it's a range because it acknowledges that different appointments and consultations differ in their complexity and the amount of mental load and time that it takes to deal with them. And that actually 35 a day, that's probably if you're doing all e-consults, actually that limit applies to e-consults. There's an expectation that you would do 50 or 80 e-consults a day. They suggest that is actually unreasonable and beyond safe limits. And being backed up, that kind of clear advice from the BMA is really, really helpful as we try and define, what are safe limits to operate in. Particularly given the recent contract changes, that we must provide an appropriate response that does not jeopardize the patient's health. An appointment with an overworked doctor might actually not be the best thing for a patient, and they might be better off going to the walk-in centre, for example. Exactly. They talk about Opal and escalation plans. So we engage with Opal locally, and it's an effort to capture and define the current stresses on that day, that week, that general practice is under. I don't think, and actually, if practices, reach a certain Opal red, then we've never done it actually, Gandhi, but you might have done it. I think you get a call from the local commissioning team to ask what's going on, I think. So have you ever got that?
So there was a good chunk of time actually when my practice was Opal red, and actually it wasn't until we went Opal black that we got a call from the local ICB team and asking, what was going on. I'm like, well, I've got nobody in practice, it's just me, so that's why we're black. I can't do anything apart from deal with everything.
Did they divert your phones to 111 or?
No, they didn't. So they took us off the DDoS register, which we actively had to do, which was a bit of a frustration. But that's one of the things that some of the guidance mentions that you can do in terms of GP access and things. But basically, we just turned around to the patient and said, unfortunately, we have not enough staff to cope with your needs. As a result of this, we are listed as black, and actually we can only deal with emergency care issues relating to general practice. Anything else, you'll be directed either to contact us at a later time, or you can access the walk-in centre or community services like pharmacy and that kind of stuff for minor health issues and that kind of thing. Because we had administrative stuff, so we could do things like prescriptions, we could do things like booking of future appointments and stuff, but we just didn't have any clinicians on the day because COVID had just roared through everybody and we couldn't get any last minute cover.
It was but I guess with that that could have happened a few years ago without Opal in place, but with Opal in place, I guess that at least provided a framework for you to engage constructively with the commissioners and with the patients to do something that was safe, rather than feeling you perhaps had to continue to accept queries when you didn't have the staff to answer them. and
Yeah,
actually put patients at risk that way. So I guess it's progress, and the further development of those systems will be a positive thing, I guess.
potentially one of the things I learned from that experience though was turning back to the system and saying, well, what support are you offering me now that we don't have the capacity to help? And unfortunately at that time the answer was, well, we've got nothing we can offer you. Like, well, yeah, thanks, great. Can I get on and crack on and deal with the problems I've got here now instead of having to waste my time reporting back to you? But hey, that is a separate issue, I think.
But only by engaging with these systems will they
Yes.
develop and become useful, I guess. So PPGs. So I guess they're just highlighting that these can be, helpful. I think when they started, they sometimes felt like a chore and an extra thing to do, but actually they can be, useful ways of getting feedback about how you're performing and actually kind of building a coalition with, a group of local patients to help support the practice in what it's trying to do and help the practice and the staff feel supported. And also actually to support the practice if you have a particularly good and active PPG to lobby for change or even influence change within other patients who aren't in the PPG. It can actually be quite a powerful tool if done right. Yeah. Any further say on PPGs, Gandhi?
I think it's an increasing area that practices need to reconsider focus on, particularly with some of the challenges we are facing in terms of capacity. And I think it is a case of sharing that message that actually the issues many practices are facing is not an access issue, it's a capacity issue. So the only people that will understand that more effectively are going to be your patients trying to access the care. And it's also, like you say, it's a good mechanism of delivering of information potentially, because actually if patients don't know how to access the practice, the person they're more likely to listen to is not necessarily the practice, but it's another patient. So actually working with your patients to help them understand those challenges, you could try and broadcast that, but we know that broadcasting doesn't always work effectively. So how can you make that work more effectively? And that is by having people working with you, co-producing that information as well to make it more effective for the patients can absolutely be a powerful thing to do.
Absolutely. Measuring workload. So I guess we talk about how much work we do and and how a lot of it is unrecognized, and we're being encouraged to measure it really, and make sure that that those activities appear on our appointment ledger, I guess, is the main way that things are currently counted. So that may be about taking things that currently occur in the background as administrative tasks, or just quick phone calls here and there about results and things like that, and making sure that those are recorded so that they're counted, so that they're valued by NHS England, and that will help with workload in the longer term in terms of getting that recognized and better resourced. External unresourced workload. The BMA have done quite a lot of work on this in the past, haven't they, to support practices push back against these things. And it's a big topic in and of itself. Do you want to say something briefly about this one, Gandhi?
Shall we come back to that? Because there's some really good examples towards the end of this document. So we'll probably cover that then. It does then talk about practice list closures. I know this is something that some people feel really challenged about, but actually if you're at that point where you just cannot cope, where you're that bubbling pan that's about to overspill and stuff, actually closing your list can be a really powerful message to take. Now, part of the challenge with this is it requires your local ICB's approval in order to close your list. However, there is absolutely something there about safety in the fact that if your practice is struggling to the point where you cannot offer safe, effective care to patients, and closing your list is an action that practice can take, and many LMCs should be supporting you in that decision if that was the case that you needed to take that on the grounds of safety. A really challenging thing may potentially be if multiple practices in the same area close their list at the same time, and that has been dubbed as a potential option for industrial action. Will we see that? We don't know. Obviously, the GPC are currently consulting in terms of what they feel to be industrial action, given the contract issues we've had recently. But it is something to be mindful of the fact that it can have an impact, obviously, on patient engagement, trust, other aspects, but actually, in some places, can be a really effective way of managing some of the challenges you're facing.
Yeah, I mean, if you just simply don't have enough staff, you can't recruit. You're going to collapse unless you do something like close your practice list. Workload prioritization. So what they're getting at here is that we have a core contract, the GMS or PMS or APMS contract, that stipulates what we have to do to receive our core funding, and then practices voluntarily engage with other types of contracts to do additional services that might come in the form of local or direct enhanced services. Actually engaging with things like IAF, QOF, and even the the PCN DES are optional. You won't get paid for them if you don't do them, but they are optional. And I guess the point is sometimes the payment you get for them doesn't reflect the cost of delivery, or sometimes you only have the resources to deliver the core stuff, and actually you can't even find or purchase the resources to deliver the additional stuff. And it's really saying, actually focus on the core stuff and actually be quite, selective and hard-nosed about the other optional services that you as a small business choose to deliver. And I think that's a very sensible message.
It is. I think it's also worth bearing in mind the other side of that story, that obviously you are then changing the service to your patients, potentially from what other practices may have, and that can sometimes be an area of conflict, not only with patients, but absolutely with the ICS or CCG as it used to be. I speak from experience because my practice actually traditionally does not provide the phlebotomy services direct to patients, because actually we recognize that to move towards that, the funding that we would receive would not be commensurate to the amount of workload it would have. And that would negatively impact the services we can offer patients. So that's then provided by, the responsibility of that is then to the ICS, the ICB, to provide that and stuff. And actually that then has implications in terms of how that service is delivered from the perspective of a commissioner versus the perspective of a user. And that can sometimes be a really uncomfortable place to be as well. So just cautions along with advice about making sure, as Andy mentioned, that the services are financially sustainable and to a degree even profitable, because if you're not making profit, then you can't actually continue to pay the staff for the work that they're then doing.
That's good. It's that profit word, isn't it? I mean, I prefer sort of surplus on contract or something like that, because it's not really going in the back pocket of a GP. It's what's being used to deliver the service, including paying the GP partners for the time that they work. But I think that's all most GP partners would ask for these days. And the PCN DES, so singled out, particularly, and they're highlighting that there is an exit mechanism, which has passed for this year, in terms you could have served notice on it by the 30th of April to leave the PCN DES. This is something that often comes up with BMA and LMCs, actually, Gandhi, and you're a bit closer to those organizations. This often comes up as in these conversations about managing workload, or even pushing back against government on some of the things they ask of general practice. It would be a big step, wouldn't it, to leave a primary care network?
And also it does mention the consequences of doing that. So obviously you do then preclude yourself from things like the R's roles. It does in terms of some of the additional funding that you would receive, and options of accessing other types of care, but that still needs to be provided. So it'll be the network's responsibility to do that. I think it's a step to take in certain situations, depending on how your relationship is with your PCN itself, and also what services you're taking from the PCN. But I appreciate it's not an option that seems to have been taken en masse as far as we've seen, although having said that, deadline only went a couple of weeks ago, so we don't know the full impact of that for this year. I suspect for the next contracting mechanism, this is going to be more of a talking point, though, for whatever comes after the PCN does.
So Gandhi, the next issue dealt with here is a mention of GP workload and management triage tools. So yeah, what do you think about that suggestion?
I mean, it talks about a focus on the type of workload that you're doing. I think this one in particular relates to the fact that the BMA do actually have a tool for this. So it may be worth having a look at it, Andy, in terms of some resources. So when you click on that link, it takes you to this tool that they've created, which is basically some guidance on how you can look at triage within your practice. So it's got triage flows. It talks about how you can use particular systems. So in particular, it's mentioned the EConsults and Accurix, or if you're going for a clinician-based resource instead. So I think if you go to the top and then on the left-hand side, there's some navigation toolbars that you can see there in terms of how you can make triage work within your practice. So it uses the concept of, it just uses the concept of what triage could do for your practice, and whether that's something that's sensible, effective to do, and whether that's based on care navigation, whether it's based on clinician-led triage, and also some of the examples of the tools that you could use as well. It's a useful document to have a look at, I think, particularly if you're looking at changing how your access currently functions, which obviously many practices are currently doing. So yeah, useful.
Yeah, I was going to say those flowcharts are quite useful, actually. We looked particularly at the second one when we were looking at recent changes to our appointment system, and it's just nice to have an authority like the BMA just provide some guidance on the general shape of how these systems might look, even if the details are quite different depending on the capabilities of your staff. Just knowing that you're doing something that's generally approved in terms of the general shape of the system is helpful. Sorry, carry on, Gandhi.
I was just going to say, I mean, then it talks about a summary part, but what I found really useful about this document was this following part. So guidance for what GPs can say no to contractually. And I think for me, this is the part that most practices just need to spend a little bit of time looking at, because I think there is a massive difference in terms of the impression that both practices and patients understand of what is core general practice. Now, this is not an extensive list, but it's a really useful list of things that actually you can look at. So it outlines what is the requirement general practice. And you and I looked at this when we looked at the statutory instruments and stuff. But, services required for the management of contractors, registered patients, and temporary residents who are or believe themselves to be ill with conditions from recovery is generally expected, terminally ill, or suffering from chronic disease, which are delivered in the moment determined by the contractor's practice in discussion with the patient. So that is the core element of general practice that we have to do. Yes, there's obviously other functions and stuff, but that's the key kind of thing that we need to have a look at. And I think, having that tool to help understand that is really useful, because then it explains some of the things that you shouldn't have to do in general practice.
So let's go through them. So automatic re-referrals resulting from so it says this list is not definitive or exhaustive. So there are other things that it's not appropriate to do, but these are some ones that occur commonly, and there could be a lot of benefit in addressing these. And I think they highlight somewhere that they have a letter pack for helping practices provide feedback to the bodies that have asked them to do things that this is not appropriate, that they should do them themselves. And that letter pack is quite useful. We've used that within our practice as well. But automatic re-referrals resulting from patients not attending a hospital appointment. So it's quite common actually for patients not to attend, or it used to be. I think secondary care got a little bit better. People used to not attend, and they used to be immediately discharged, only to obviously need to be re-referred again by the GP because there was a reason they were referred in the first place. So we should not need to do that. Do you want to take the next one, Gandhi?
Yeah, so routine follow-up of hospital procedures where the GP is not best placed to follow this up, nor is it clinically appropriate. So, I mean, this can be various different things like, post-review of surgical processes where actually a follow-up appointment is really sensible, not just discharging them with a view that primary care will then deal with all of that. Whereas patients that have had further investigation, those results are not due back yet, and then being discharged again from clinic, and therefore as a result of that, asking primary care to follow that up for them and stuff. And there's similar things that you'll see. So it comments in the next one about re-referral to specialty care, about how it's, just I have seen situations where patients have been discharged from clinic with a view to being told, refer back if it's not improved, but actually it's not improved. So therefore it was always likely to be a referral back would be needed rather than a follow-up appointment. So I think, that's a challenge, I think, in my view.
Yeah, absolutely. Or referral to different specialities, from one speciality to another. They give the example of physio, which is more, orthopedic type medicine, requesting a referral to rheumatology, and actually the department in which they're working, their physiotherapist should be capable of referring to the rheumatologist. That's how I read.
Or, for example, spinal teams asking primary care to do the referrals to chronic pain teams when they feel there's no surgical input needed. That just seems like a bonkers one in my head.
That's so common. Yeah, no one appears to be capable of referring to the chronic pain team apart from general practice, it would appear. Yeah. The other thing as well, which I think we have to be careful of, because often secondary care can get around this by just saying, if necessary. They just put that at the end. And there might be occasions where, a further review might be needed, but a lot of the time it isn't. So I think we just need to be careful in terms of how secondary care use that term. Fit notes or sick notes. So often it's possible for hospitals to do this, either at discharge from an operation. They might have had an acute medical admission for an issue and they're not going to be fit for work immediately afterwards. So where the hospital has the opportunity to do these, they should be doing them, and we should be asking the hospital to do those. Patients referred to by hospitals back to practice solely for the purpose of prescribing a medication which is the responsibility of the specialist. So so I guess commencing medicine, it's the responsibility of the specialist, isn't it? I mean, this is very clear for red drugs and certain classes of amber drugs that they can only prescribe. But still, occasionally we will be asked to prescribe those actually, and and we still do have to send that back to the hospital and say that we cannot do that. And I guess and actually often they will write a letter say try this medicine, where they could have done the prescription in practice, even if it's something that we're capable of prescribing. They could do the prescription and the patient could start getting benefit of the medicine. Doesn't happen a lot, but it shouldn't happen.
I think important when it comes to this situation of prescribing medications from hospital-based care, I think the actual action of prescribing medication needs to be done in those situations, because it makes you go through the thought processes of, is this medication safe? Is this medication appropriate? And actually, because secondary care sometimes don't do that process, they don't realize the implication of what they've asked for, and therefore the journey for that patient becomes even more stunted, because actually that medication may not have been appropriate medically, may not have been appropriate organizationally because it's a restricted drug in some way, shape or form, or actually in terms of the delay to care because of the transfer of information can be really a hindrance in that situation. So I absolutely agree that clinicians should be going through this process, and then continuations can occur from primary care if suitable, but actually that input point has to be the secondary care clinician's decision point, not ours.
Absolutely. Following up test results ordered in the hospital, which are responsibility of the requesting clinician. So I don't see this very often these days, but I guess it shouldn't happen. But I think maybe some in the past, I've seen blood results done following a brief admission with a request to the GP to follow it up and maybe take some action which is conditional on those blood results. And we often say we're not the house officer, or we're not the junior doctor of of this medical team. I find myself thinking that less these days. So I think there have been improvements, but that sort of thing definitely shouldn't be happening. I guess sometimes around imaging results, it might happen as well, or sometimes it seems to happen unintentionally around imaging results. A hospital team might request an MRI scan, and it just takes a very long time for them to action the MRI, result, and we are left to review the results with the patient. But actually, that's the responsibility of the hospital. So follow-up isn't, sometimes that's actually telling the patient what's happened or having the discussion, and not necessarily leaving it to the GP to do that.
I think this one for me is quite simple. If you've requested a test, the responsibility is on yourself to follow it up, not passing that over to primary care. That's not just sensible guidance, that's not just common sense, it is actually GMC guidance as well. And delegating it doesn't differ from your responsibility of actually understanding that test result, the need for it, and the subsequent management of it. So actually, it is the responsibility of the person who's requested the test, not passing the buck.
Absolutely. Arrangement of hospital transport, which could be done directly between the hospital transport service and patients, giving the patient control over timing rather than involving practice staff. I don't think my staff are involved in negotiations around transport anymore, but I'm sure it's on the list. So there must be areas of the country where this is.
I think there are. Occasionally I've had this challenge as well, that we've been asked to arrange the transport for patients to attend their outpatient clinic appointments, and actually don't even know how to do that, to be honest. It's not something we're involved with. So I think it's just recognition that all members of staff need to be aware that there may be processes that are appropriate, and the default answer should not always be go to GP.
Yeah. And sometimes when there's a third party involved, this is where confusion can occur. So sometimes if a patient is in a care home and they need transport somewhere, sometimes the care home staff aren't sure, and they might ring the practice, and practice staff, unsure what their role is, might begin to be involved in organising some transport. So I think it's just reminding us to be really clear that it's not the practice's responsibility, and it's the hospital department's responsibility to get them where they need to be. And finally, arranging other tests and investigations that should be part of the commissioned secondary care service. I was wondering if I can think of some specific examples here, but I guess
an interesting one I'm going to postulate to you, Andy. So the pre-referral process, actually, should that be general practice? Pre-referral.
Prereferral.
So in many areas, they are now looking at having certain tests being done before you can even refer a patient. is that actually appropriate in those situations, or actually is that responsibility of secondary care, because they potentially are then going to do another battery of tests once they've seen the patient, which may or may not have been different based on the initial investigations and stuff. It's a complex area, but I think there are also other examples for more specialist tests, in particular things like scans and that kind of stuff. They actually should potentially be arranged by the specialist, so then they can determine what is the most effective test for that situation, rather than a delegation to primary care, who may be doing it because they don't actually know the implications of that test as well, and could miss something.
Two things spring to mind. So I think sometimes in musculoskeletal medicine, somebody may see a physio or somebody who doesn't have the right to request a certain test, even though actually they may be working within a system and with experience sufficient to really know when that test can be ordered, like an MRI scan of a limb or a back, for example. And they might actually write back and say, I've seen this person, and they need an MRI scan of their lumbar spine. And actually they're saying it should be part of that commission service. So actually, if that's something that's going to happen often, or at least more than just a few times, then it should be part of the commission service, that they can or can turn to someone to request that. Just in response to your question, Gandhi, about the pre-referral tests, it's really interesting that you've highlighted that as a potential source of shift of responsibility, care, and activity from secondary care, because it really is. And I think actually the pre-referral tests, in my mind, should be those tests that lead to the decision to refer, and those that maybe are very timely in terms of the nature, in terms of when they need to be done or how quickly they need to be done. But anything that just supports the next decisions in secondary care and would have traditionally been done after first appointment in secondary care, I think they should do that, and that they should have a mechanism for organising those before they see the patient. That's my response to that question. So that brings us to the end of the BMA's guidance to support both workload and well-being in general practice. I think it's a useful document to prompt conversations within practice, particularly around well-being, and then a useful checklist really to check if you're doing more than you need to in a few of those areas that are high risk of practices stepping up and doing more than they need to. So I think it's a good document for practice to have a look at. It's nice and short.
Definitely, and highly recommend you do have a look at the document if you want to. It's not big, it's 3 pages and stuff, and the links to it are down below. Alternatively, you can check out some of our other episodes, including our focus one on QoF QI wellbeing, which is coming up right about here, that you can have a look at, and let us know what you think in terms of your actions down below in the comments, because we may then end up doing some more feedback episodes on what you think or would like to know, like we have done in terms of our episode about finding out about feedback for primary care, in terms of some of that QoF QI work on the access side of things that's probably coming up right here. And as always, we're here to help tech enhance your primary care and learning. And we'll catch you in the next episode.